Management of diabetes during sick days. This is Mona Mamdouh Hassan, Professor of Pediatrics, Pediatric Department, Head of Diabetes, Endocrine and Metabolism Pediatric Unit, Cairo University. I'm sharing with you this subject on management of diabetes during sick days on the 14th of November, which is the World Diabetes Day. Here I'm sharing with you the latest from the International Diabetes Federation that it is estimated that 1.1 million children and adolescents aged under 20 years have type 1 diabetes. And the number of newly diagnosed cases each year from the age of 0 to 19 years are 128,900 children diagnosed with type 1 diabetes. The blue circle you can see at the upper left corner, this is the symbol of the World Diabetes Day, and it is a symbol of uniting for the support and advocacy for diabetes. Children with diabetes are prone to infections just as their peers, and they might experience more frequent infections if their diabetes control is suboptimal. According to the International Diabetes Federation, incidence of type 1 diabetes among children and adolescents shows annual increase of around 3%. And so the frequency of encountering a sick child with diabetes is expected to increase. Being sick causes fluctuations in blood glucose, commonly hyperglycemia, and occasionally hypoglycemia. Also, if not properly managed, this impacts quality of life. And so it is really important that all pediatricians and healthcare professionals should be aware of the risks and the principles of management of sick days in diabetes. I would like to start posing a question. Which of the following symptoms you consider most challenging in the child with diabetes? When the child presents to the clinic being sick? Is it fever, sore throat, upper respiratory catarrh, wheezy chest, vomiting, diarrhea, abdominal discomfort, pain, frequency or dysuria? Actually, all symptoms are important to consider in a diabetic child with diabetes having these symptoms. But actually, vomiting is always the symptom that causes panic to parents and makes them deal with it inappropriately by stopping the insulin. And so, going to the second question, which of the following acts you consider most risky in the sick child with diabetes? Is it consulting a pediatric specialist, home management of the illness, missing urine testing for ketones, stopping insulin temporarily, encouraging sugar containing fluids? Which of those? Again, missing testing for ketones is important. Encouraging sugar containing fluids should not be feared, but actually, the most problematic action and risky action is the stopping of the basal insulin temporarily, especially if it's the basal insulin, not just the insulin doses of the meals. And this is an act that many parents go for when they find their child is not eating properly or starts to vomit. According to the International Society of Pediatric and Adolescent Diabetes Clinical Practice Consensus Guidelines, which are released in 2018, sick day management in children and adolescents with diabetes has had important rules that should be considered. The 5 general principles of management of diabetes during sick days include: one, Sick day guidelines include insulin adjustments, and these should be taught soon after diagnosis and reviewed at least annually with patients and family members in order to reduce this risk for DKA and for severe hypoglycemia. Two, more frequent blood glucose and ketone monitoring should be done. Ketones can be tested in blood or urine, but actually what is available in Egypt are the test strips in urine. Three, do not stop insulin. Four, monitor and maintain hydration with adequate salt and water balance. Five, treat any underlying precipitating illness to reverse the condition. And so what are the risks in the sick child with diabetes? Now we can realize that the risks are in the child with diabetes include hyper or hypoglycemia, dehydration, and the child can progress to ketoacidosis. I will emphasize on vomiting as an important symptom to realize because it can be caused by the illness itself, gastroenteritis, acute viral hepatitis, food poisoning, surgical condition, or others, but can also be caused by a severe attack of hypoglycemia. And most important to realize, it can be caused by insulin deficiency with hyperglycemia, and so risking the occurrence or progress to diabetic ketoacidosis. And this is very important to realize that vomiting can be the first symptom of a failure in the insulin action itself. Vomiting then is considered a sign of insulin deficiency until proven otherwise. And so it's very important to educate parents to monitor the blood glucose, but also always to monitor the ketones in urine. Antiemetic can be used, but always consider diagnosis of the underlying disease first and avoid steroids unless necessary. Of course, we know that some of the antiemetics contain steroids, and so it's better to avoid those types of antiemetics to avoid progress to diabetic ketoacidosis, as steroids is an anti-insulin hormone. Don't forget that vomiting imposes the risk of hypoglycemia, but also imposes the risk of hyperglycemia, especially if this vomiting is a sign and the symptom of insulin deficiency or inappropriate management of diabetes. Okay, with vomiting, we know that parents panic from the fear of hypoglycemia, and usually they choose to avoid the insulin. And this is the problem. This is where the problem starts, and the child then progresses to diabetic ketoacidosis. So what should we advise the parents when there is vomiting? Not to panic and to put the child or adolescent at ease, to monitor the blood glucose frequently, test ketones in urine. If available in blood, it would be more accurate and earlier in detection. Identify the cause of the vomiting. Give an antiemetic avoiding steroids, as we've said. Correct the hypoglycemia slowly by giving the glucose gel or honey. And this can be absorbed from the mucous membrane of the oral cavity to make sure that the child is not below 70 milligram per deciliter. Correct the hyperglycemia by giving extra insulin, and this is usually needed every 2 hours by giving around 5 to 10% of the total daily insulin in the form of a short-acting or a rapid-acting insulin. Keep monitoring the blood glucose and the ketones regularly, better every 2 hours, and move to the hospital when necessary when the child is critically ill and is not improving within the first 12 to 24 hours. During vomiting, sources of simple sugar and electrolyte should be provided containing salts and sugar. One of the good options to use is the WHO ORS solution, and this is encouraged for emergency use during sick days when there is loss of appetite, which is common. And this is to provide hydration and to compensate for losses of water and salt. Sugar containing liquids are helpful to prevent the occurrence of hypoglycemia and starvation ketosis. And this is important to emphasize because some parents think that they should not use sugar containing liquids with their children with diabetes. Always remember that supplying a balanced insulin and carbs according to the metabolic needs during illness is what we should follow. And this is to prevent and treat the occurrence of hyperglycemic ketoacidosis, the occurrence of euglycemic ketoacidosis, or the starvation ketosis. Hyperglycemic ketoacidosis will occur when there is inadequate insulin for the control. And so always make sure that the insulin is effective, the insulin used is effective, because sometimes the main problem is that the insulin used is not working and it's not effective, either because of storage or because of any disturbance in the delivery system like the pen or the pump or the syringe. As for the euglycemic ketoacidosis, this means a ketoacidotic state, but in the absence of a high blood glucose. The blood glucose is below 200, and this is an important entity, which is, although it's not very common, but it happens frequently, especially if there is a gastrointestinal illness or vomiting. Starvation ketosis will occur when the child is lacking calories and lacking energy. And in this situation, we should supply proper carbs. If the patient has loss of appetite, then we can give sugar containing fluids to maintain his energy and to be able to give appropriate insulin doses. The euglycemic diabetic ketoacidosis, how does it differ from the non-diabetic ketoacidosis? As we know, the diabetic ketoacidosis is traditionally defined as a triad of hyperglycemia with a blood glucose more than or equal to 200 milligram per deciliter, an anion gap acidosis with pH below 7.3 and bicarb below 15 millimole per liter, and increased plasma ketones with ketonuria. With euglycemic diabetic ketoacidosis, this is essentially a diabetic ketoacidosis, but without the hyperglycemia. Serum glucose is below 200. This is very important to realize because ketones should always be tested, even if the blood glucose is below 200, so long that the child is not in his normal condition and he's sick. These two photos, they show the testing of ketones in urine using the urine test strips. On the right, you will find that the test strip is showing a high blood glucose in urine, as shown in the darkening of the second square on the strip to dark green, but the ketones are negative. We always encourage and advise the parents to check the colors on the container itself of the strips. On the other side, on the left, you can see that trace acetone or ketones have appeared. And this is important to notice because once ketones start to appear, we have to act by giving extra insulin doses every 2 to 4 hours and keep checking until acetone is cleared. Other special considerations related to the sick days with diabetes include inquiries and facts that we hear from parents. Parents always ask, are children with diabetes immunocompromised? Are children with diabetes more prone to infections? And how to boost immunity in a child with diabetes? And this I will address in the coming couple of slides. Very important facts to teach the parents and always advise that monthly menses in girls should be dealt with like the sick days with diabetes. And this means that during menses, many girls can enter into a ketoacidotic state. So during menses, always regularly check the blood glucose to make sure that extra doses are given, and check ketones in urine to give extra doses and reverse the ketoacidotic state. And this is because it's a state of stress, and there are anti-insulins that need extra doses of insulin to be given. The second fact is that being sick can be the first presentation of diabetes, and relating the clinical condition to the illness alone delays the diagnosis of diabetes. This is a very important issue to raise with all healthcare professionals, because the first manifestation of diabetes can be simply overlooked, being diagnosed as an underlying illness. So whenever a child is coming with an illness in the pediatric clinic and does not appear to improve, or there is no an actual explanation for his illness, always check the blood glucose. Diabetes can increase the susceptibility to infection, and the mechanisms underlying the association between diabetes and infection are not actually fully identified. But it is known that there are suggestions from relevant studies and research that diabetes suppresses the innate immune defenses, and also the hyperglycemic environments enhance pathogen virulence by promoting bacterial replication and attachment to epithelial cells. What is very important to emphasize always, that insulin therapy restores all these functions, restores the innate immunity defenses, and also reverses the hyperglycemic environments that enhance the pathogen virulence. And so, just adjusting the insulin therapy in a known child with diabetes, or starting insulin in a newly diagnosed diabetes, this in itself will reverse uh, the susceptibility condition, and it restores the immunity of the child. Finally, my key message is children with diabetes can be more prone to illness, and this poses acute and chronic complication risks with impact on the quality of life and also on the healthcare resources. In the child and adolescent with diabetes, illness might be infection, or it can be a disturbed diabetes management. So always consider that the insulin is working effectively and is taken as advised. Never stop insulin in a sick child, but all is needed are adjustments of insulin and calories. Keep a healthy, balanced diet. Caregivers and the child or the adolescent must be educated and supported to know how to deal with sick days. Illness can be the first presentation of diabetes, and so should always be considered as a diagnosis in the sick child in the pediatric clinic. Always check blood glucose and contact a specialized clinic or center to manage safely the child with diabetes. And thank you for listening.